to start us off with this one here?
I can start.
Good.
So we have a punch, and this looks inflammatory to me.
Good.
And so looking at the skin, it just looks like, orthokeratosis. I didn't see any para. Um, Looking at the changes, it looks like mostly interface changes to me.
Okay, good.
Um, and so, and then I saw some like perivascular inflammation close to the interface as well.
Okay. What kind
Um,
of cell are you dealing with mostly here? It's kind of a pale slide, but
Yeah, so I thought this was like a vacuolar interface dermatitis.
yeah, and then these cells were mostly,
Oh, lymphocytes is what I
yeah,
was thinking. Yeah.
that's good. Excellent. Okay, good. Good. That's exactly right. So it's a vacuolar interface dermatitis. Um, what about the epidermis?
Yeah, the epidermis, it looks like, yeah, that the basal layer had some, you know, liquefactive degeneration a little bit, and that I saw some like disc keratosis um
Okay.
and some of the cells up
And the epidermal redi are effaced.
there. Oh yeah, it's kind of like blunted and um
Yeah, there's almost no epidermal redi ridges here. Um, it's got a little bit of acanthosis, which is kind of interesting. I'm sort of curious as to why you've got, usually when you lose the epidermal redi, you kind of get some thinning of the epidermis, but we don't have that here. So that might be a potential clue to the diagnosis. I don't know. So when you see that pattern, and you're exactly right, what else do you notice here, though, by the way, at this power? You're here, the
um
tenocytes you described. There's the vacuolar alteration, which you described quite nicely.
Yeah, then there's the melanin incontinence or some are those
Yeah,
melanophages?
good. There are melanophages here. Um, maybe some serophages too, but I think you're right. Most of them are going to be melanophages, I think. Maybe there's even some, pigmented cells up in the epidermis. Okay. So when you got this pattern, that's very good that you got that because there's not a gazillion diseases that give you that pattern. So you have to but there is a differential. So what's your differential diagnosis here? And why do you think the one diagnosis might predominate over another?
Yeah, so it's looking at things like potentially lupus, potentially erythema multiforme, or um, viral exanthem. I was thinking of graft versus host, um, and then maybe even like early T cell lymphoma. Um, but
Okay, so those are reasonable things to think about. So now let's just go back to those and unpack them and see, based on what we see here, which of those is the most likely diagnosis that we can make with no history. Of
yeah.
course, obviously, I don't think they're going to give you this on the board examination, say, what's the diagnosis? If they were going to show you this, they'd probably give you some information and then expect you to be able to correlate it. But given that we're doing it without any history, at least initially, let's go through some of those and see which ones you think are the more likely, or we can likely exclude some of them more than others.
Yeah.
So you started off with lupus. So what's good for that? What's not so good for that?
Um, so what's good for it is, I guess, just the basic like vacuolar interface dermatitis. I was trying to look for like mucin, things like that,
Good.
or
Yeah.
um
And did you see any mucin?
I didn't know.
No, no. So that's not so good for it. And then what about this epidermis here?
Let's see. Like in lupus. Mm,
Well, if you see, like, let's say you see somebody that's got subacute lupus erythematosus or maybe relatively long-standing acute subsystemic lupus erythematosis with skin lesions,
yeah.
uh, when you do a biopsy of their skin, what do you usually see? You see this change for sure, but do you
Yeah.
see this type of change up here?
No, I guess there's too much dyskeratosis. Not, I guess there'd
Well,
be
you can
more.
get a lot of dyskeratosis in lupus, so I wouldn't say that. But that markedly thickened epidermis, highly
Not
unusual.
okay.
If you ever look at a biopsy of somebody that's got chronic DLE or subacute lupus, usually it's a super thin epidermis. You can kind of almost see through it and see the
Yeah.
telangiectasies and the poikiloderma and all those kind of changes there. So that would be a little funny for lupus too. You
Okay.
can get epidermal hyperplasia sometimes in DLE, you can get like a verrucous LE even, but this would be a little funny. So no mucin, no thinning of the epidermis, two strikes against lupus. But this is good for it. So you're right about that. And you said erythema multiforme. Um, what's good about that and what's not good about that?
What's not good about it is, let's see. I mean, I didn't really see any eosinophils. I know you don't always have to have EOs, but and then I didn't really. I guess there is some spongiosis there, and I didn't.
Yeah, you do usually, yeah, you often do see spongiosis in relatively early erythema multiforme. Um, if this were kind of a later stage lesion of EM, you'd expect some, more confluent epidermal necrosis, and we just have these individually necrotic keratinocytes at the junction
Yeah,
with the effacement of the reedy ridges, and then you've got the melanophytes. So this is probably fairly chronic. In
yeah,
other words, this probably didn't happen just yesterday. And if we saw early EM that's in a stage of evolution and it's just got the dyskeratotic keratinocytes at the basal cell layer, usually you'll see a normal architecture of the epidermis because it hasn't had a chance to get the reedy ridges to be effaced or anything. And you'll see the dyskeratotic keratinocytes often with some spongiosis, like you said, in early lesions of EM. So if this were EM, it'd have to be kind of a funny chronic EM, maybe been going on for a long time, which would sort of not fit if you've got this basket weave pornified layer, because we usually kind of think of that as being kind of a relatively, an EM, it happens kind of relatively quickly. It's kind of funny that this has a basket weave pornified layer. I think what may be happening here is that this person has had this thing for so long, they've kind of almost developed a symbiosis with their condition, and they're now making relatively normal cornified material, interestingly enough.
yeah,
So not great for EM either. It'd have to be a really unusual EM. But this part, yeah, I mean, definitely you do see individually necrotic keratinocytes in EM. I believe you said mycosis fungoides is a choice.
yeah.
What's good about that and what's not so good about that?
I guess the chronicity of it could be good for mycosis fungoides and the thickened epidermis. Um, yeah, it could be one of those thin plaques. But I didn't really see any particular atypia. I know you don't have to early on.
No, you're right. You don't have to early on, but I agree. I don't really see any atypical lymphoid cells. But what else is kind of missing for MF that you really would like to see that we don't really see much here?
Epidermotropism.
Yeah, good. There's really no epidermotropism, and you can rarely. I've seen it a few times, not very many times, get dyskeratosis in mycosis fungoides. Not commonly seen, so that's not great for it. So we'd probably say, it's chronic. That goes along with it, but there's really no epidermotropism. There's really this dyskeratosis is unusual. Um, you said viral exanthem. Which virus would you be
Yeah.
thinking about?
Um, I guess I didn't really see any inclusions, so I guess nothing that really leads me to like HSV or VZV or
Yeah,
um
yeah. And viral exanthems usually don't give you an interface dermatitis unless it's maybe causing secondary erythema multiforme in a patient with herpes or something. So that'd be kind of funny.
mm,
Uh, let's see. I think you might have mentioned drug eruption. Could that give you this pattern?
that yeah, the interface pattern, I think,
Yeah.
but
And if you like to be right in conferences, you can always say drug eruption because
yeah,
they can do.
never wrong.
So yeah, this could be a long-standing drug eruption. So that's absolutely true. That's why we don't like to get biopsies that say drug eruption versus blank, because the answer is kind of yes. It always can look like that. So what's maybe potentially bad for a drug eruption here, but not necessarily bad for drug eruption,
Um,
or something's missing here.
just no EOs, yeah, just mostly
And no
lymph.
EOs. But you can have the most florid drug eruptions in the world without a single eosinophil. So, they can be type 4, you know, allergic reactions. They don't have to be type 2 with EOs, so you don't need eosinophils at all. And then you mentioned graft versus host disease.
Yeah, I think this could be good for graft versus host.
Yeah,
Um,
yeah. And there's really no way that you would just know that. And so that's why I wanted to go through that exercise with you. They're not going to put this on there. This happens to be graft versus host, but there's no way you would just know that just looking at this. So
yeah.
that's what you would do in a case like this. You would come up with a differential diagnosis, and then you would look on the pathology request slip, and you would hope that they would put something on there that's meaningful, not like rash or something like that, and say,
Yeah.
oh, bone marrow transplant and develop this long-standing eruption, rule out graft versus host. And sure enough, this is what it looks like. So it's pretty characteristic. Um, and what we just went through is why you might suspect it if you saw something like this. But if I were just seeing this blind without any other information, my first thought would probably be an interface drug eruption.
Yeah.
And why does a drug eruption and a graft versus host eruption look similar? Well, they're kind of the same type of immune reaction. You've got a T cell mediated response that's reacting to the skin. So basically, in a drug, you've got an antigen, hapten that comes up here, and it really does the same sort of thing. So it makes sense that they would look the same. So basically, you're not going to be able to tell it apart histologically. Now, if you look in the textbook and start reading it, talk about satellite cell necrosis and all this, that, and the other, and with no disrespect intended to the people who wrote that, that's garbage. You see satellite cell necrosis in lymphocytes and single attacking keratinocytes and whatnot in the epidermis, and drug eruptions and erythema multiforme and all those other things we mentioned. So that doesn't mean anything. You have to put it together with the clinical correlation, and then you see this. And this would be more of the interface type of graft versus host. There's about 4 or 5 different histologic findings that we see in GVHD. You can see some that are more florid, like an erythema multiforme. They get lots of epidermal necrosis. You can see the sclerodermiform variants of graft versus host. You see a lichenoid pattern in GVHD. So a lot of different histologic manifestations of graft versus host. So that's good. Okay, we'll move on to the next one.
Yes. So this looks like a punch biopsy on
Yes.
a hair-bearing area. See a lot of hair follicles.
Okay. Which hair-bearing area do you think you're dealing with?
I think likely the scalp.
Yeah. Why the scalp? Why does that jump out at you initially?
It's like a very deep punch biopsy, and the scalp is very thick.
Okay. Well, they can take deep biopsies of the back too, so.
Oh, but also like multiple hair follicles.
Yes, and look where they're situated. That's the
Very,
key. They're deeply rooted in the subcutaneous fat. So that's pretty much the only place on the body where you get this many hair follicles that are way down in fat like that. And is this the normal number of follicles here in subcutaneous fat?
no, it's a lot of follicles in the subcutaneous fat. It's more than normal.
Well, actually, no, it's believe it or not, it's actually diminished.
Oh,
It's less. Normally, we should see about, 7 or 8 probably in a punch biopsy of this size. We see 4 here. These used to be down there, most likely. These probably were there not too long ago, but something's going on with them. So what can we say about the patient? We're looking at the scalp clinically. Is it going to look like your scalp or look like a different type of scalp?
probably like alopecia of some sort.
Yes, good. It's going to be an alopecia. Very, very good. So we got a deep punch biopsy of an alopecia.
Mm-hmm.
Now, there's some things in dermatopathology lend themselves to a very, very simple, almost mathematical approach to applying criteria to them. Alopecia is one of them. The other one's paniculitis. Now, you try to apply the criteria. Sometimes the diseases don't read the textbooks and they don't obey the criteria. but you can sort of apply certain, you just kind of go down a pathway when you're dealing with things like paniculitis and alopecia. So here we're dealing with an alopecia. So do you recall how to go down that pathway? What's your approach when you're looking at an alopecia? So when you're taking the board examination, you say your heart rate doesn't go up 1 beat, because you say, I've got an approach here. I'm just going to systematically go through it. I'm going to make the proper diagnosis, and then I'm going to move on to the next case.
An approach to alopecia, I'll be honest, I don't think I have like a very systemic one, but I guess I'd start with scarring versus non-scarring.
Okay, good. You can go with that. You can go with scarring versus non-scarring. What I was taught was you kind of go with permanent versus non-permanent. And then you say, is it, inflammatory or non-inflammatory? So for example, a non-inflammatory, quote, permanent alopecia is androgenetic alopecia. Now we know it can be non-permanent if you give enough minoxidil or inject platelet-rich plasma or whatever, but theoretically that's a hormonally driven permanent alopecia that's non-inflammatory. So that's one way that you can look at it. And then you can say if it's a permanent inflammatory alopecia, then you say, well, is there scar tissue and inflammation or no scar tissue and inflammation? And then you say, if there is scar tissue and inflammation, where is that localized to? Is it targeting the follicle? And if it is targeting the follicle, which part of the follicle is it targeting? Is it targeting the bottom part of the follicle, like in alopecia areata, for example, where it's targeting the bulb of the hair follicle? Or is it targeting the upper part of the follicle, like maybe near the infundibulum and the isthmus in that area? And then if there's scar versus non-scar, so for alopecia areata is non-scarring. It used to be permanent. Now that we have JAK inhibitors and things, we can reverse that, but we didn't have that, years ago. So you can still think of it in many cases being analogous to permanent alopecia. And then you've got other conditions where you get destruction of the follicle. And when it's destroyed, it ain't coming back. And it can be destroyed by like a rifle shot right at the follicle, or it can be destroyed by like an army invading the entire area and massively destroying all the follicles. So as we're looking at this one, what do you think's going on here? You think there's inflammatory or non-inflammatory here?
I do think there's inflammatory. I see
Yeah,
mixed inflammatory pattern.
And where's that inflammation located?
Located like around the hair follicle and the dermis.
Yeah, good. It's targeting the follicle. It's targeting the follicle. That's probably to the side of the follicle. If we cut deeper sections, we probably see a follicle right around that area too. So it seems to be hitting the follicle, not sort of getting everything and just destroying the follicles along the way. Like for example, like in folliculitis decalvans, that starts off as a suppurative folliculitis, ruptures, and it just sort of blasts everything. So here it's really going after the individual hair follicles themselves. Okay. And what kind of cells are we looking at? What kind of inflammatory cells do you think we're seeing here?
So when I was looking, I see a lot of neutrophils and then also some lymphocytes and a few EOs.
Yeah, at this power, the cells look pretty dark. Probably betting on lymphocytes as the predominant cell. Most likely lymphocytes. There are probably going to be some other cells too, like you said, and you've probably already seen this at high magnification, so you found those other cells there, but mostly lymphocytes. Okay, we're going to higher magnification. And now what do we see? What's going on here, for example?
Also some like neutrophils and then maybe a few EOs in there.
There's some histiocytes here, but what's this right here? What do you think happened right there?
Oh, so multiple hair follicles that are in like multiple hairs in one hair follicle, like the polytrichia.
Yes.
Trichia.
There's no residual hair follicle here at all, basically. Everything is destroyed. These are the ghosts of 4 little hair follicles that were once going on there. Now they're surrounded by fibrosis. There's granulomatous inflammation, which is a secondary finding in this process. So it's secondary. So when you get this targeting of these follicles and they rupture and then you get this secondary change, that's not the primary inflammatory process. If you look over at this hair follicle, we see the primary process here. these are lymphocytes attacking the outer portion of this follicle. There's still a little residual epithelium here. So it's targeting the follicle. Here's another one right up in this area here. So that's the cross section. So what's the most likely diagnosis here?
Maybe LPP, Lichen Planopilaris.
Yeah, you can take the maybe out.
Okay.
It is Lichen Planopilaris. And this is what Lichen Planopilaris does. And this is a later stage lesion of Lichen Planopilaris. What's kind of interesting about Lichen Planopilaris, you kind of would think, and these follicles too are damaged. You see this perifollicular fibrosis here? This is earlier stage, and this is probably tangentially sectioned. So this is really higher up somewhat. So it's probably kind of in the mid-reticular dermis. This is probably about the level of the infundibulum here. And you get this perifollicular fibrosis here. It's an onion skin perifollicular fibrosis occurring at the level of the infundibulum and the isthmus where the stem cells live. And once you destroy those cells, it's over. Game over. You're never going to reverse this. So, you can't, that's why if somebody's got Lichen Planopilaris in an early stage, you want to be super aggressive with them. Give them high dose steroids, give whatever you can to kind of decrease that inflammation, because you really don't want it to get to this stage, because once it gets to that stage, you cannot reverse that. So that's why you want to really try to get it fast. And notice the scar is confined to this area. It's got a tropism for these follicles, which is kind of interesting. It doesn't really involve the interfollicular dermis, as you see here. And what's also interesting is that there's no lichenoid inflammation up here. So it doesn't look like typical lichen planus when it's Lichen Planopilaris. A lot of these patients, you'll see them and they may not have other stigmata of Lichen planus. They may just have the follicular involvement alone, like in the Graham-Little syndrome. A lot of times you'll see patients with LPP of the scalp, but they don't have any Lichen planus anywhere else in their skin. They have it only on the scalp. So it's kind of an interesting disease. It may actually be somewhat different than classic Lichen planus. And if you see the differential diagnosis between this and discoid LE, you often will see a lichenoid infiltrate in DLE. So it's kind of a paradox. You sort of think that you would see more of a lichenoid process in Lichen planus. You actually tend to see more lichenoid inflammation in the D junction up here with DLE than you do with LPP. So this is a nice example of Lichen Planopilaris. So if you go through that sort of approach that I just mentioned, you'll be able to make the diagnosis. Now, what are two things that are in the differential diagnosis of this pattern right here that we're looking at? Two diseases.
With the polytrichia, I would think of maybe one thing I think of is like CCCA, but then the polytrichia makes me think
Yes,
of
absolutely. Yes, absolutely. CCCA. It looks almost identical to this.
Yeah.
And what's the other disease?
Folliculitis decalvans.
Well, not really, because that doesn't usually give you the direct perifollicular fibrosis like this. Folliculitis decalvans just destroys everything.
Maybe FFA.
Yes, FFA. And so if you're a histopathologist and you're looking at three diseases that all have virtually the same histology, it kind of makes you scratch your head and say, is it possible these are really the same disease in some way? Is CCCA really Lichen Planopilaris in a different ethnic group that's associated with trauma and use of, pomades and hair straightening and this sort of thing? And so, I've always sort of thought that because they look so much under the same under the microscope that they may be variants of the same process. I'm still thinking that may be true. We actually got a paper that we published on that before. So it's more kind of a thought concept, but to me, I think these diseases are all very similar because they target the same area of the epithelium, the same area of the follicle, and they all look histologically the same. So anyway, that's my 2 cents worth on that. Okay, so I'm going to do this one.
I can take this one. So this is like a shave versus maybe an excision of a dermal nodule. So I think this would be more in the neoplasm category. And it's very well circumscribed. It's when I looked closer, I didn't see too much atypia, so I was favoring benign neoplasm for this one.
Yeah, it's very small. It's quite symmetrical. I mean, we don't have the whole thing, but this is probably kind of the end of it if you were to draw a line around the whole thing. And it's super well circumscribed. It also, notice how it almost has this cleft between it and the surrounding stroma like that.
Mm-hmm.
That's also a sign of benign. The other way they could have treated this is treated like a pilar cyst. They could have done a little incision over it and it probably would have popped out. Probably would have been nuclear, but they took a shave of it. So those things all favor benign. Okay, so the next step, obviously, is whether it's going to be epithelial or non-epithelial.
Yeah, so this one, I am favoring non-epithelial.
Good, non-epithelial. And, we like to keep things very simple in dermatopathology. The simpler, the better. So what are the three main non-epithelial cells that we look for?
We can look for like smooth muscle cells,
Good, smooth muscle.
like a histiocytes or fibroblasts,
Good, fibrohistiocytic.
vascular potentially. I'm
Well,
not sure.
that sort of goes down the realm of other, if you will. But the other main third one we think about is
Oh, maybe neural.
neural. Good.
Okay.
Those three, just very simple. Neural, fibrohistiocytic, smooth muscle. Boom. Then we're going to look and see if we can tell which one of those three it is. And if it doesn't look like one of those three, we may start then thinking, well, maybe it's a weird, squamous epithelium that's become spindle, or maybe it's a funny spindle cell melanocyte, or maybe it's a funny spindle cell endothelial cell, like you suggested. So those are some other things that can be spindle, but those are the three main ones I want you to think about. So let's look here. And what do we see here? Of those three, which do we kind of like here?
Yeah, I was favoring more of smooth muscle.
Good, excellent. Now there's two types of smooth muscle in our skin, right? There's smooth muscle that comes from, that's most commonly seen associated with what structures?
I guess you can see smooth muscle like near, trying to think here.
Well, if somebody comes and scares you in Halloween.
Oh, yes. Like near the pilosebaceous units.
Yeah, the erector pili,
yeah.
and then also the erectile tissue of the body. That also has smooth muscle. And then what's the other place where there's smooth muscle? That we're looking at right here.
Around the vessels.
Blood vessels.
Mm-hmm.
Yeah, blood vessels contract and restrict, so you can get smooth muscle cells, myofibroblast and smooth muscle, involving blood vessels. So we've got these cells, these spindle cells with these blunt cigar-shaped nuclei that don't look like these lazy S's swimming in a sea of fibromucinous stroma, with this pink cytoplasm here, and then we've got this blood vessel. So what kind of smooth muscle do you think we're looking at here?
More of the second kind surrounding the blood vessel.
So what's the diagnosis of this?
Yeah, so with the blood vessels, the smooth muscle, and then also the adipocytes, the fat, I was favoring an angiomyolipoma.
Okay. So forget this part for a minute. I want you to say angiomyolipoma here. And then you're right. When you look at it, say, that's angiomyolipoma on this part, but then you've got all these fat cells in it. They don't really belong there. And so, yeah, when you see this, you can say this could be an angiomyolipoma, which is a pretty rare bird in the skin. We don't usually see it in the skin. Now you've kind of opened a little bit of a Pandora's box. So I'm going to ask you a couple of additional questions about it. Where is this usually seen? You probably know the answer, but I hope you do.
Yeah, I think it's normally in the kidney.
Well, actually, it's in the perirenal area, perirenal area. And what disease is associated with that? I'm sure you know the answer to that too.
Tuberous sclerosis.
tuberous sclerosis. Now, if we saw this in the skin, does the patient have tuberous sclerosis?
I don't think it's as commonly associated when it's in the skin.
Yeah, the association is much looser in the skin. We don't really, it hasn't been definitively proven that if you see an angiomyolipoma in the skin, that they're going to more likely have TS or not. I would probably check the patient because we know that this thing occurs in that perirenal area. So just make sure that they don't have some other stigmata of tuberous sclerosis. And of course, you need to know everything there is to know about TS. You need to know all the clinical manifestations, the dental manifestations, the brain X-ray, basal ganglia calcification manifestations. You need to know everything there is to know the gene of this. So just make sure that you know all of that for the board examination because they will ask you about that. Okay, good. So that's an angiomyolipoma, very rare entity. For every one of these, we probably see 10,000 just garden variety angiomyomas. I don't know if these are as painful or not because there's just not, that many of them that we see. But theoretically, you think maybe it is painful. Okay.
Good morning. I could take
Morning.
this one.
Good.
We're examining a punch biopsy that's been sectioned, or two punch biopsies for vertical and horizontal sectioning, which drives us to assume that this is likely a workup for alopecia. When we look at the broad buckets of the types of alopecia, I don't see any scarring and I don't see any inflammation. So as we continue here, if we examine the, like for example, the left on the screen here, we can see there's some trichomalacia in the hair follicles themselves and a normal number of hair follicles. And if you zoom in, we can actually see pigmented casts. Given the lack of inflammation, this points us to a trichotillomania.
Very good. Excellent. Trichotillomania. So that's virtually pathognomonic. When you see this, it is pathognomonic. It means that they've been twisting and pulling their hair shafts. So they got trichomalacia. The fact that you identified that, that's good. There's some things in dermatopathology that are pathognomonic. This is one of them. Now, is this the entire process that's going on in this person?
That's an excellent question. Based on the nature of the question, I suspect there is something else going on. I did not identify another pathology.
Well, if you look at this piece over here, okay, this is the horizontal section here. It's probably taken around the level of the, infundibulum of the follicle. What about if it is? What does this look like to you? Does that look like kind of normal? Everything normal here?
I see a great number of anagen follicles, and the sebaceous glands were larger than I was anticipating.
Yeah. There's prominent sebaceous lobules here. This almost looks like a biopsy from the face. That's cut, horizontally, but it almost looks like a biopsy from the face. If it looks like it's the scalp and it kind of looks like the face, then you should be thinking of androgenetic alopecia. So the person might have background androgenetic alopecia, and if you're looking at trichotillomania, and dermatopathology and dermatology, more than dermatopathology, dermatology is really a microcosm of almost all of the specialties of medicine, right? We've got pediatrics, we've got internal medicine, we've got surgery, we've got dermatopathology, we've got psychiatry. So maybe we need to put on our psychiatry hat here. And we see some androgenetic alopecia here. It's a youngish person. There's zero sun damage, nothing, no solar elastosis, anything like that. What if this were a woman that was developing hormone-driven androgenetic alopecia?
And is playing with the.
Happy with that?
I could see this being some trichomalacia in a patient who is playing with the hair that is. They're either observing the AGA or they're examining hirsutism. So that would be like they're kind of opposite scenarios, the one being a man, the other one being a woman.
Yeah, a man starts losing their hair. They say, okay, let's get some minoxidil, and or maybe we'll shave our head. We'll look like a famous movie star or something like the Rock or something. They don't care that they're losing their hair. But a woman, maybe it's got hormonally driven alopecia. Maybe she's all nervous about it, and maybe she says, "Oh my goodness, my hair's falling out," and she starts twisting and pulling it, and then sure enough, it gets worse. So she compounds the problem, possibly. Yeah, a man could do that too, but that's one way. And another situation where we see that is in patients that have alopecia areata. Trichomalacia it should not be seen in alopecia areata that hasn't been manipulated. But we commonly see secondary trichotillomania in patients that have alopecia areata for that very reason. Oh my God, my hair's falling out, and they reach up and they start twisting and pulling it out themselves. And they're nervous about it. They're losing their hair. Maybe they're nervous that causes the alopecia areata to begin with. And then they just compound the problem by inducing secondary changes here. So that could be what's going on here, because this has got a little bit too much in the way of sebaceous glands here, just for garden variety trichotillomania. Now, you said what stage of follicle are we looking at right here? High magnification view. This would be probably a dermatopathology board examination question, but I'm asking you, since you zoomed in on the diagnosis so quickly, what stage of the hair follicle are we looking at right here?
The center one, I am leaning towards anagen.
You had a 1 out of 3 chance.
All right, then I will adjust the catagen.
Change it. Catagen, yes, catagen. Catagen, the cell is undergoing a catabolic reaction, right? In other words, the hair follicle is dying. And so we've got all of these individually necrotic keratinocytes here within the follicle. So that's what happens in a catagen follicle. You get thickened, glassy basement membrane zone here. So this hair follicle was nice and happy and living happily ever after. I think this one's still an anagen over here. All systems go, no thick basement membrane zone, nice outer root sheath with glycogen. This one's living happily ever after. This one is starting to die. They've been twisting and tugging and pulling, and if we looked up at the top, we'd probably see the trichomalacia. And so these individually necrotic keratinocytes and the thickened glassy basement membrane zone, this whole thing is like contracting. It's contracting, and it's going to end up as a fibrous stella, as a little tiny strand of collagen with a small bud of cells at the in the area of the isthmus, and it's going to maybe lead to a new follicle that may form at some point in the future. So that's catagen. If you see dyskeratotic keratinocytes in a follicle, it means catagen. Now, we can tell, even looking at this follicle, that this is not likely to be alopecia areata for a couple of reasons. That's a harder question to answer, but there's one reason is that if you get alopecia areata, usually if there's catagen follicles, they're all in catagen at the same time. So in other words, you get the same stimulus that comes in and causes all of them to go into catagen at the same time. And that's why you shed the follicles, the hair shafts all get shed in that one little area, kind of all at the same time. And this one, if you look at these patients clinically, it looks like a patchwork. It doesn't look like nice, round, smooth areas where all the hair shafts are gone. You've got some hair shafts, and you've got no hair shafts, and you've got some broken hair shafts, and things kind of look like, like a patchwork of alopecia. It doesn't look like a classic, nice, smooth alopecia that you see with alopecia areata. So it makes perfectly good sense. So good. So this is an example. We had the inflammatory alopecia before, and now we've got a non-inflammatory alopecia here, and we're able to use these other findings, the trichomalacia, the catagen follicles in different stages of evolution of the follicles, to be able to render the diagnosis of trichotillomania here. So that's great. Okay.
Hi, good morning. I got this. So on first view, this looks like a punch to me. When we look a little bit further, if this is an inflammatory or neoplastic process, this seems to be more focused on the neoplastic. When we took a little bit deeper, seems to be more well circumscribed, uniform collection of cells there. I didn't really notice any atypical cells when I looked into more of a higher power in this particular
When we look at
presentation.
this at low power, though, you know, we had the angiomyolipoma a minute ago. What's the predominating, or at least it's 50% of the volume of the lesion in this case?
So predominantly, it was more of a like a basaloid appearance to me.
We've got two things, right? We've got this, and then we've got this.
So that's, I think, more of like a fibrous stroma surrounding those basaloid
Good.
cells.
Good, excellent, stroma. Now, when we look at this thing, you said it's well circumscribed. Mainly the thing that we look at that's well circumscribed is that stromal component, right?
Mm-hmm.
Kind of interesting. The stroma is probably contributing a significant component to this lesion. And what do you think they sort of, you know, felt here clinically when they saw the patient in the clinic?
I potentially felt that this was maybe some form of like follicular tumor of some kind.
You think when they saw this patient in the clinic, they said, ah, follicular tumor?
I mean, um,
Highly unlikely. But
yeah.
what do you think they did think? I mean, they took a punch excision of the lesion. What do you think they thought this was clinically?
Did they think maybe this was a basal cell? Since you know.
I doubt it. I mean, to me, look how deep this thing is.
Yeah.
Just, I mean, so you see this patient in the clinic.
Yeah.
It's probably going to have zero surface change, probably no color change. It's mainly going to be a palpation diagnosis, right?
Right.
You're probably going to say, yeah, there's a subcutaneous nodule here of some kind.
Mm-hmm.
So they might have thought it was going to be what's the
Like a
most
cyst?
common subcutaneous nodule we see in dermatology?
A cyst?
A cyst, yeah.
Okay.
They probably thought this was a cyst. And, you know, and it's small, it's well circumscribed, and it's got mostly stroma, so it's going to feel kind of firm, I would imagine. So, and then you look at it and say, well, okay, we think it's neoplastic, and you said it's epithelial, and you said what kind of epithelium you think it is, which is
Right. Basaloid.
basaloid, and we have really multiple different potential basaloid kind of cells. Which kind of basaloid cell do you think we're dealing with here?
Let's see here.
This is a clue here. This is a clue.
Let's see. That more like a cuboidal appearance, or?
Well, no, I'm just talking about what kind of differentiation, what kind of basaloid differentiation are we looking at here? Which part of the normal structures in our skin, well, obviously a number of them can give basaloid cells, but which of those is leading
Oh,
to
like
this?
like a nodular. I mean, is that what you're asking for in regards to this is like more of a nodular appearance?
Well, it is, they're all little tiny nodular aggregations, but what structure do you think these are recapitulating in the skin? What normal structure is this recapitulating? You know it, you're just not saying it.
Talking about like the hair follicles, surrounding hair
Yeah,
follicles?
follicle. Good, follicle. Hair follicle. This is a little papillary mesenchymal body here. That looks like the dermal
Mhm.
papilla, the hair follicle right there. So yeah, this is a primitive follicular neoplasm. Good. And I agree that it's benign. And sometimes when you're looking at one of these individual lesions like this, you know, you say, well, you know, let's look at the individual. Is this one little small nodule is small and well circumscribed and whatnot? If there's a cleft here, it's going on between the stroma, right?
Mm-hmm.
Okay. So what's the diagnosis here?
So I was thinking more of like a trichoblastoma.
Yeah, trichoblastoma. So what is a trichoblastoma? Who
I
came
think
up
of
with
this,
that?
isn't it very similar to a trichoepithelioma, but in this particular cases where the basaloid cells are more predominantly in the deeper dermis rather than in the superficial
Yes.
layer.
Yeah, that's reasonable. I think that's fair enough. And it's also tends to be a little bit more primitive than a classic trichoepithelioma. You know, trichoepithelioma is going to give you a little bit more of these more well-differentiated areas here with more papillary mesenchymal bodies. And, you know, this is kind of an interesting lesion because this has so much stroma to it. You know, often you look at a trichoblastoma and maybe about 80% of it is epithelial and maybe 20% is stroma. Here we've probably got about 60-40. It's more stroma than epithelial. But as a general rule, what I was pointing out to you earlier is when you're looking at the benign epithelial follicular lesions, stroma tends to predominate at least somewhat over the epithelial component. The stroma is part and parcel of the soil seed component of that lesion. When you're looking at a basal cell carcinoma, for example, by far the majority is epithelial. There's just a little bit of the fibromucinous stroma most of the time in a basal cell. And if they're clefting within the lesion, it often occurs in a basal cell, obviously, between the epithelium and the stroma. In these type of lesions, if there's clefting, it occurs within the stroma itself. So that favors benign adnexal neoplasia. And there's a number of different forms of trichoblastomas, which you do not need to know for the board examination. I don't know that they would really expect you just to come up with a diagnosis of trichoblastoma on this slide, even, by the way. But if you've got that, that's great. But they would probably show you more likely a pretty classic trichoepithelioma or maybe a desmoplastic trichoepithelioma. So make sure you kind of know what those look like in addition to this. But this is a nice example of a benign adnexal neoplasm with follicular differentiation, and it just so happens to be a trichoblastoma here, which means that it's more primitive than a trichoepithelioma. Okay. We'll do this one.
Good morning. I can take this one. So this looks like a punch
Good,
on possibly like the trunk or extremities.
good. It
Looks
could be an excision actually too, by the way, a small excision. See?
It looks neoplastic.
Good,
From this power, it looks pretty symmetrical, pretty like, you know, sharply demarcated or well circumscribed right up there. And pretty
Good.
small. So overall I favor benign.
very good.
And then it looks like a bunch of melanocytic nests kind of right at the DEJ with clefting around them.
Okay,
The melanocytes in particular, they look like kind of small, spindly, and heavily pigmented.
okay,
A good amount of melanin just kind of in the superficial dermis as well.
good.
I was looking for atypia or like mitoses. I don't think I really saw much of that at all.
Good. Would you really spend a lot of time searching for those if you sort of saw the other features that you
Probably
sort of-
not, because at low power it did look pretty benign, but
Okay.
you can see
What about what's going on up here?
a little bit of melanin has made it up to the stratum corneum.
Good. If you look carefully here, you might be able to barely make out that pink structure there. It's
Is
not the
that a
world's best example, but
body?
well, what did you say again?
Is that a Camino body?
Camino body. Yes, that's probably a Camino body. It's not the world's best example. So what's the diagnosis?
For this one, I was favoring a pigmented spindle cell nevus of Reed.
Okay, okay. And what is that thought to be a subset of type of nevi when you have a pigmented spindle cell tumor of Dr. Richard Reed?
A subset of a Spitz nevus.
Yeah, subset of a Spitz Nevus. Good. Okay. Let's see. There might be a mitotic figure in that cell right there. Do you see that?
I'll take your word for it, Dr. Cockerell.
Is that going to change your diagnosis?
I don't think so, no.
No, it's not. Not going to change your diagnosis one bit, because you can get mitotic figures in Spitz's nevi very commonly. It does not mean that it's malignant. There's a whole lot of different variants of Spitz's nevi, out there. This is one of them. This is mostly a junctional type of Spitz Nevus. And that heavily pigmented spindle cell tumor of Reed is one variant of that. These things often look pretty black. This person, they probably saw it and maybe they said, oh my goodness, this might be a melanoma. So I'm going to do an excisional biopsy and just excise it at one fell swoop. And then we got back to diagnosis and, they were, hopefully they weren't worried about it anymore. Now, a lot of dermatologists are paranoid about Spitz nevi. The Spitz nevus itself is not a pre-malignant lesion. It's not going to turn into cancer. The main problem is that if you get an inadequate biopsy or you see something that's got some criteria that may look a little asymmetrical or whatever, that it can be difficult to diagnose the Spitz nevus from melanoma, sometimes histologically. And the diagnosis gets missed by the pathologist. And so then it gets undercalled, and then the next thing you know, there's a lawsuit and everything. So everybody's paranoid about Spitz nevi today, so they almost always excise them. In a young child, if it's a classic dome-shaped orange lesion, or maybe one of these dark, heavily pigmented lesions, you don't really need to worry about it. I mean, you don't really need to freak out and say, oh my God, there's a chance of melanoma here and all that sort of thing. And order genetic studies and get back some slightly abnormal, fish abnormalities, and then everybody gets freaked out. Just don't go down that pathway. I mean, these are benign lesions. When they've got these features that you described here, you don't really need to be too worried about them. And this one's been completely removed, so it's never going to come back and harm the patient at all. But even if this were just a shave biopsy, and you might have had a little extension to one margin, you don't always have to go back and re-excise those, especially not in children. The second most common patient population where we see this are middle-aged women, often on the extremities, the legs and whatnot. A lot of dermatologists, if you get that diagnosis back in a woman or a middle-aged individual, they'll go back and re-excise those, but you don't really have to if it's a pretty classic Spitz nevus like this. The other thing I would just mention is that some parts of the body, like the ear, if you biopsy nevi on someone's ear, they very commonly have a spitzoid histology to them. I don't know why that is, but there's certain parts of the body where nevi develop certain special features based on the site where they're located. And on the ear, they commonly have a spitzoid morphology. So you want to make sure that you don't overdiagnose that as a melanoma in a young individual in somebody's ear, and then they have to get it whacked off when it's totally benign. So it's not good to overdiagnose either. You need to sort of be like the three bears. You want to, Goldilocks, you want to be just right. You don't want to overdiagnose or underdiagnose. And most people tend to, overcall these or call them atypical spitzoid melanocytic lesions and recommend removal. And something like this, you don't need to do that. You can call this a straightforward Spitz nevus or Reed nevus. You don't need to do anything more. Totally removed. Okay.
Hi, I can take this one.
All right.
So this is a punch. There's some scant like inflammatory infiltrate, but we see it mostly around the follicles. Mostly lymphocytes.
Okay.
Honestly, this was one of those that we weren't completely sure about.
Okay. It's good to have some that you're not completely sure about all the time. That's what creates myelin. If you know the answer, it's automatic. But if you have to work through it, struggle a little bit, that's good. So we see something at low magnification, don't we? It's pretty sparse.
Mm-hmm.
I want to call your attention to this piece over here. It's pretty subtle, but I want you to look at this structure right here. Here's the fat.
Uh-huh.
It's normal. Pretty subtle, but is that normal?
I think you would usually see a whole sheet of fat.
Well, this is a good biopsy. I mean, person's got quite a bit of nice fat here. I don't know that they're obese or anything. They got fat in the specimen. means it's a good biopsy. But if you look at somebody's fat here, is this normal?
No.
No, what's wrong with that?
Is that muscle or?
No, it's not muscle. It's collagen. And
Uh-huh.
it's normal to see that thick collagen in somebody's fat. Is that normal?
No.
No, no, it's not. This is normal. That's a normal septum of the fat here. Very, very thin, 1 or 2 layers of collagen. This one's got about 100 layers of collagen. And they're thick.
Mm-hmm.
Might even be some diminished fibroblast focally. So markedly thickened septa right here in this one area. We're going to go back to the other piece now, and let's take a look up here. Now, at this power, you said it was perifollicular, but is it really perifollicular?
It's kind of everywhere, but just a little bit.
It's interstitial, isn't it?
Yeah.
Interstitial mostly pattern. And we got lymphocytes in here. We're going to get higher magnification, and you're going to probably see some other cells in here as well.
We saw some EOs as
Saw
well.
some EOs, very good observation. You saw some EOs. You might even
There's-
see this cell over here that's got some perinuclear cytoplasm with a small amount of immunoglobulin in it, which is a
Plasma?
plasma cell. So we got a mixed infiltrative lymphs, EOs, and plasma cells. And we start looking, and maybe there's some loss of fibroblasts up in here with homogenization of the collagen bundles.
Mm-hmm.
So now what are we kind of beginning to think about? We don't see a lot of sclerosis in here, but we're seeing some incipient changes here with we're losing some fibroblasts in here. We're beginning to replace some of the fat here, possibly. We've got a markedly thickened septum down here that shouldn't be there. This isn't an easy one. It'd be boring if they were all easy for you guys. So let's go back. So
Uh-huh.
let's start thinking of diseases that give you an interstitial mostly process in the last couple of minutes that we have here.
I'm not sure.
Okay. Things like urticaria,
Uh-huh.
things like interstitial GA, things like
Mm-hmm.
KS, things like metastatic breast carcinoma, things like cellulitis, and then
Mm-hmm.
infiltrative lymphocytes, plasma cells, EOs, with thickening of the subcutaneous fat septa here, and maybe incipient sclerosis. Sclerosis.
Morphea or
Morphea, yes, the inflammatory stage of morphea. Inflammatory morphea, early morphea. Might not even feel thick yet. But whenever you see that lilac color, those patients they got that pinkish lilac color, you biopsy that sometimes, this is what you see. You see the thick white, when you biopsy the really thick ivory looking lesions, those are going to give you the square biopsy with the diffuse sclerotic collagen. This is early morphea. And if you get it really early, sometimes you'll see the so-called puffy phase of scleroderma. You'll see edema of this thickened septa, and you might have a little bit of that here. A little bit of that here. That's when you get the puffy phase. When they come in with their hands, they say, well, their hands feel thick and I can't really move them as much as I used to. And you reach over and you rub their dorsal skin and it doesn't move over their subcutaneous fat very well. That's the early stage, puffy stage of morphea. That's what you see when you biopsy that. But this is what you see when you get that early inflammatory stage of morphea. And it's one of the differential diagnoses of the interstitial mostly pattern. So interstitial mostly with EOs, plasma cells, lymphocytes, thickened septa. Think of the early inflammatory stage of morphea like we see here. Probably a little tough to show you on a board examination without some information, but at least know what the pattern is here, and you'll be able to get it the next time you see it. Okay, well,
Thank you.
good job, everybody. Thanks for being here this morning. You guys have a great holiday, and we'll see you guys in 2025.